All right, good afternoon and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is particularly geared toward long-term care and skilled nursing facilities, but we encourage everyone who's interested to attend. During today's webinar, we'll be talking about updates to cohorting guidelines for long-term care. Everybody's going to be on mute, but if you have any questions, we just want you to enter them into the chat at any time, and we will address them at the end of the session today. And we also encourage you to join us every Wednesday at 2 o'clock, just like this, for more webinars in the series. My name is Mitzi Vince, and I'm a communications specialist with Quality Insights. And without further ado, I'll get us started. And again, just want to remind you, we'll follow up with all of your questions at the end of the presentation. So on today's episode, we're talking again with Pam Meador. We had the pleasure of speaking with Pam just a few weeks ago about today's topic, but there have been some recent updates, and she's back to give us some insight on what has changed. For those of you who might not be familiar with Pam, she's the Director of Regulatory Services with the West Virginia Healthcare Association. She serves as the association's Director of Regulatory Services, and in her role, she works primarily on policy and survey review, and she also she helps member facilities navigate challenges in the healthcare field. She's a registered nurse, and she's worked in long-term care for over 30 years. And prior to her work for the Healthcare Association, she worked for more than 10 years as a project coordinator at Quality Insights, where her work focused on quality improvement assistance to long-term care facilities. So welcome, Pam, and thank you for joining us again to talk about cohorting amid the COVID-19 pandemic and how that has affected long-term care and skilled nursing facilities.
Thank you, Mitzi. It's always fantastic to come and visit with you guys.
All right. So we talked several weeks ago about the topic of healthcare cohorting amid the COVID-19 pandemic and how things have changed for long-term care and skilled nursing facilities as a result of that. And then I think it was just a day or two later, or maybe even that very afternoon.
It was that day.
The CDC issued updated guidance about that. So before we dive into those updates, I just wanted to give our listeners kind of a brief overview in case they didn't catch the last podcast on cohorting in long-term care and how some of the ways that has changed with COVID. And then we'll kind of take a deeper dive into some of the specific updates that the CDC issued earlier in February. So can you kind of give us an overview about what you talked about last time, Pam?
Sure. Last time we talked about cohorting and the fact that in long-term care, cohorting is nothing new. We are old hats at putting the same people with the same infections together or a history of the same infections, especially the multi-drug resistant infections such as your MRSA and your VRSA and all of those other C. diffs and all those other wonderful little acronyms that we use for infection control. We're old hats at doing that. We know that, folks that have these histories of these infections can't go in with people that have even if they don't have any infections, if they are immunocompromised, or if they have a portal of entry, such as a PEG tube or a catheter or a wound or anything like that, we know we can't cohort those types of conditions together. What COVID has done, it has really risen to the top of our cohorting priorities. We've had to section our facilities off to where we've had a COVID positive wing, where only folks with COVID positive for COVID can be on that wing or in that section of the facility. We are only permitted to cohort folks that are positive with COVID and no other kind of infection together unless they have the same exact infections. We've had to have staff that are cohorted also. Our nursing staff, we've had to have those put in the facility's positive COVID wing They have to be the housekeeping staff, the nursing staff, all of those dedicated to that COVID positive wing. Our break rooms have changed. We've had to learn how to make sure that entrances are dedicated to that COVID positive. I mean, there's just so many changes with COVID that we've had to make, and we need to, or we have been very successful in it, despite the media that we've recently received. Our nursing homes and our long-term care facilities have been very, very successful in keeping this pandemic at the absolute lowest rate of mortality and deaths, and actually very sick residents. We've done a fantastic job as an industry. When this first started, as everybody remembered, there wasn't any PPE. Everybody had to scrounge, and they had to use, they had to use the exceptions and the critical levels. We just come through it fantastically and have done a great job. So that's basically, that's a high level cohorting, what we have to do for infection control in the long-term care facilities. Very, very high level from last time.
All right, thanks, Pam. So one of the guidance updates included changes to the verbiage about what it means to be fully vaccinated. Can you tell us about that update?
I sure can. And if you guys are okay with it, we've developed a document that will be available through Quality Insights as well, to kind of make it easier for you to find answers and to find links and things. So if you don't mind, Mitzi, I'm going to go ahead and share my screen in order to show folks this document. And I'm gonna take myself off video, because so maybe you guys be able to see a little bit better what's going on. And plus, I had some eye surgery done, some old lady cataract surgery done, and I may have to get close to the screen, and y'all don't need to see all that. So, so Mitzi was mentioning the changes in some of the verbiage. One of the main things that they changed with this last update were, can you see my screen, Mitzi? Are you good? If I move it, can you see it?
Yep, I can see that.
Okay, fantastic. Some of the main changes were with some of the definitions. One of the big changes was here with fully vaccinated, and what they did, fully vaccinated, when they state fully vaccinated, it still just means fully vaccinated. 2 weeks after your the 2-dose series, or 2 weeks after a single dose series, is still considered fully vaccinated after your second dose of the 2-dose series, and then after the first dose of the 1-dose series. That is still fully vaccinated. However, what the change has come, if you'll look at the bottom of the screen here, it talks about up-to-date vaccinations. That is the person who's received all recommended boosters. So it's a new verbiage, and it just explains what it means to be fully vaccinated and to be up to date. So I don't want you to change your NHSN thought process, because when you're documenting an NHSN, you're still considering fully vaccinated as just the primary doses. It does not, as of yet, include booster doses. So when anybody is talking about that, those two different descriptions, that's what they mean. And another good thing about this is this document is in here. It gives you the links to discuss about, to take you to where the CMS and CDC discusses these different definitions. I always talk about utilizing the QSO memos and the links within the QSO memos, because we as long-term care have to follow those memos. and the links within those memos takes us to these same places. So please be aware that when you are looking for rationale as to why you have to follow a certain thing, if it's in the QSO memo and the link is there, then, and it links to the CDC guidance or whatever you're trying to find, that means that we have to follow that. So that's some of the different definitions. Cohorting remains the same. COVID-19 unit remains the same. And then explains the definition of exposure. When they talk about if someone is exposed to COVID-19, it gives you an actual true definition of what you need to be looking for. Another item that they really specify is isolation versus quarantine. When you're quarantined, that means you are physically distanced because you may be able to transmit COVID-19. You have potential transmission, and we need to do transmission-based precautions on you because there's a potential that that person may transmit COVID-19. Now, isolation is the same transmission-based precautions, but it's if they are fully positive, if you have a positive COVID-19 person, that is isolation. So that's the kind of the difference between between quarantine and isolation. And then we can go a little bit deeper into that in a bit.
All right, thanks.
So yeah, go ahead.
And so kind of related to what you're talking about here as far as quarantine goes, I understand that another part of that updated guidance focused on quarantine for residents who are asymptomatic. Can you tell us a little bit more about that and how it differs from previous guidance for those types of residents?
Yes, absolutely. And that's another good thing with this guidance, which, by the way, was approved by the West Virginia Department of Health and Human Resources. So I know you guys have a lot of Pennsylvania folks, so there may be some differences. So be aware of that. So difference in asymptomatic, we talked about isolation versus quarantine, but what you need to know are the differences. Prior to all of this, we had a 14-day quarantine for those that were non-vaccinated. Those that were vaccinated were not quarantined. And that's still kind of the same, except for the couple of differences. So we're going to look at this document here. The differences are outlined under quarantine on the left column and isolation on the right. For quarantine, you've got a 10-day quarantine for asymptomatic residents who are not up to date with vaccinations. Notice it says up to date. It does not say fully vaccinated, and have had close contact to someone with COVID-19. And then also you have a 10-day quarantine, including residents who are newly admitted and not up to date with their vaccination. Now there's a 7-day quarantine option, which is residents sorry, my phone's going off. There's a 7-day quarantine option when the resident has a negative viral test done 48 hours before the planned discontinuation of transmission-based precautions. So they're still in their 10-day quarantine, but if with it before 48 hours, if you pull a viral test on them, then they can get out in 7 days if they have a negative test and they have not developed any symptoms. You'll notice at the bottom of this little block, it says, please see the complete guidelines for other options. There are tons and tons of if this, then that, such as immunocompromised folks or whatever. So we couldn't put all of the different scenarios within the summary. So we included a guidance to that so that you could go back in there and look, well, this is a different situation. This is what's going on. So you can go back to the guidance and see. You'll also notice up to date has a link as well. And when I was telling you up there about the definitions of what CMS and CDC considers fully vaccinated and up to date, that link takes you directly to that. It also takes you directly to the close contact definition. So you don't have to go searching for that as well. Now, back over to isolation. So when isolation will end, this is what it's telling you when you're going to take these folks who are in isolation. And remember, that's a positive COVID. They're positive for COVID. When isolation ends for those who were asymptomatic throughout their infection, it tells you that they are, unless they're severely immunocompromised, at least 10 days have passed since their first positive viral test. So you can take them out of isolation at that point in time. Isolation ends for residents who are not mildly to severely immunocompromised when at least 10 days have passed since their symptoms and at least 24 hours have passed since they've had a fever without the use of reducing medications. And we had a really interesting question about that, and I'll get to that one after the last and, which is their symptoms, for example, their cough, etc., has improved. We had a question about that 24-hour no fever thing, and it was, what if they're on Tylenol routinely for pain or whatever, and their fever is gone, but they're still on that Tylenol. If they had a fever, if they were taking that Tylenol, the way that but you can refer to your physicians or your medical provider, but the way that I interpret it would be, is that if they had a fever and they were still on that Tylenol and it still has come down and they're still on that Tylenol or whatever they're on, then that would be considered 24 hours have passed without the use of extra fever reducing medications. But that you would refer to your provider for that information. We were talking about asymptomatic. We'll do testing after asymptomatic. So that's the COVID unit. I'm sorry if I'm scrolling too fast. You guys will get a copy of this if you're interested in it. So I don't, but I just want to make sure I'm hitting the question completely. On this portion of the slide talks about quarantine best practice, and it just gives you when you have a resident and you're wondering whether you need to put them in quarantine, and if they're asymptomatic, what do you do, or what's your criteria? Of course, they're not up to date on their vaccinations. They're a newly admitted resident, or they have been out of the facility for more than 24 hours. If they've had a known exposure, you'll want to consider quarantine if they are not up to date with their vaccinations. But if they're up to date on their vaccinations, and if they're moderately to severely immunocompromised, you may want to consider doing a quarantine for them. And that's an option that the CDC has put in for the infection preventionists within your facility and your medical providers to kind of determine for the little frail residents who you may want to quarantine if they are severely immunocompromised. So that's what some of the changes with asymptomatic versus symptomatic. If they're symptomatic, we automatically quarantine and we test them and then determine what our next steps are. So I hope that answered that.
It does. And I don't know if you would like to kind of talk a little bit about what some of those exceptions might be, or some of the options. I know you mentioned that there are links in the document to the CDC where they talk about the various options regarding quarantine and isolation. Can you give us some examples of that, or maybe give us a little bit more insight on why those are so varied?
Sure, absolutely. Everybody who is within the long-term care, of course, have different needs. If some of the residents that you receive are extremely frail, if they are very immunocompromised, if you get your residents that are that have cancer and they're on chemotherapy and they're severely immunocompromised, you need to really look to see what the guidance says. If they're on dialysis, if they're doing all of these and they're very sick, and you've got to be careful though, because for example, somebody who's on dialysis, it used to be that if we were quarantining everybody, if they went out for if they went out for an appointment or whatever, and dialysis folks sometimes go out several days a week, they would be in perpetual quarantine. So you've got to really individualize it. You have to look at the different situations. You have to look at the residents' comorbidities. I think most people would agree with me when we would talk about those who have really, when COVID has hit them, if they're on hospice, it's something that we need to really look at and think about how we want to best protect those residents. And these guidance, they have so many things that if the resident, what if they refuse quarantine? What if the visitors still want to come in and the resident wants them to come in even though they're in isolation, they're positive for COVID? Those are the exceptions. Those are the things. And CMS has given us a little bit of wiggle room on how we can work with these guidance. If let's talk about visitation for a second. If you have, the CMS guidance says visitation's open. If people want to visit, they're to visit, even if they're positive for COVID. But if you have an outbreak within your facility and you can't control it, like you've done everything you can do and people are popping up positive every week and all the time, and nothing you do is controlling this outbreak, as long as you are working with your local health department and also not only willing to stop visitation per their recommendation, but also stop admissions, then there are changes that you can do within the guidelines to pause visitation, let things kind of get controlled, and then restart it. And that's within the guidelines itself, but those are things that you have to be able to read. You have to be able to make sure you're working with your local health department before this happens. And there's just so many caveats and things that we can look at and kind of determine the answer to throughout these guidances. Is that an example? Is that good?
That is, Pam. Thank you.
Okay.
And before we kind of get into any listener questions, before we get to that, can you recommend where facilities can go for more information about the guidelines? And I know that we will provide the document that you're going over now. We can provide that and make that available to everybody. But is there somewhere from the CDC or CMS or somewhere like that that they should go for updates, continued updates? Sure,
absolutely. I always, to the members of the Healthcare Association, I tell them to always look at the QSOs. Always click on the links within the QSOs, which are the memos, the CMS memos. And the reason I tell them that is because they always take you to the most updated stuff. I don't like to download this stuff on my computer. Main reason, they'll change it without even telling you. If we didn't attend the CMS open door call the day that we done the other podcast, you wouldn't have known that they were making updates on February 2nd. So I always suggest go through especially QSO 38 and 39 and the updated ones. Those are the ones that have the links to the most recent guidance as of right now. There's links to the healthcare provider guidance that has changed dramatically. And it was in January, like January 21st, that those changed, when folks can come back, when they can, all of that. It's within the QSOs. And I really strongly suggest that you work with the QIO. They are so knowledgeable with what's going on right now. There was a podcast, and if you didn't attend it, it was going over one of the most recent visitation memos, and it was with Patty Austin, and she did a absolute fantastic job. And if you haven't watched that, you need to go back and review it, because she really went over a lot of little, a lot of the things that are questionable, and she explained it, and it was so easy to listen to and so easy to understand. So the QIO, and also here in West Virginia, at the Healthcare Association, we work with our members all the time on how to navigate this COVID world. And same thing with Pennsylvania. I'm sure the Pennsylvania Healthcare Association is available as well. So those are, and if you want me to, Mitzi, I can provide you the links to the QSOs so folks can just directly click for them to them with
yes,
them.
that would be great if you could do that. And then I'll also be sure to include those links when we get everything posted as well.
Great.
All right. Thank you, Pam, for taking time to provide us with your insight. We'll get to, do have a couple of questions in the Q&A that I'll get to. I wanted to remind everyone, if you want to reach out to Pam directly, you can call or text her at 304-573-6776. And you can also contact her at email at pmeador@wvhca.org. And lastly, I just want to say thank you to all of you that are out there listening or watching. And you can check out our other interviews that we've been doing in this series by visiting our website, which is www.qualityinsights.org/QIN_vlogs and pods. And that's VLOGSNPODS. So at this time, if you have any questions, I just want to again encourage you to enter them into the chat or the Q&A box. And while we're waiting, I also like to remind everyone about next week's topic on the use of root cause analysis, and wanted to remind you also to be on the lookout for our weekly e-bulletin called the Last Minute Lowdown, which covers a summary of our office hours topics, which if you don't know about that, we have office hours every Tuesday at 8 a.m. and every Thursday at 2 p.m. It's in a live chat format where you can just log in and type in a question that you have regarding this week's topic that we covered, or if you have another question about a healthcare improvement related topic, feel free to ask that as well. And we will have one of our subject matters get back to you as soon as possible on that. And that'll be almost immediate because we're on standby waiting. And then also we'll include in that e-bulletin the recording of this week's webinar, and then resources that are specific to immunizations, long-term care, and skilled nursing facilities as well. So one of the questions that we had in chat is if you can share the referenced presentation, which we are going to be doing that. We'll include that information when we get the webinar posted, and that'll also be in our e-news bulletin that we send out on Fridays. So we do have a couple questions in the Q&A, and the first one says, going forward, it is extremely difficult to expect facilities to reserve beds on another unit or away from others to cohort COVID residents, nor do facilities have enough staff to dedicate them exclusively to COVID-only residents. Often it's 1-to-1 or even less of a ratio. So how can facilities develop flexible plans using private rooms within neighborhoods to safely isolate their COVID-19 positive residents?
That is an excellent question, because I'm telling you, we don't have staff to just do one-on-one, and if you've got one positive COVID patient, that's just, it's just not possible. So when I was reading the guidance, and we can look at it closer, but when I was reading the guidance, it talks about dedicated space. And, prior to COVID, when you had somebody with RSV, you would have to place them in transmission-based precautions and in a private room or however you do it. And folks would have to utilize, you know, the proper PPE and the proper procedures for transmission-based precautions based on the fact that you don't want your whole building getting RSV. And RSV is extremely contagious, just as is COVID, especially Omicron. You know, it's extremely, you know, contagious. So when you read the guidelines, read closely what it says about the dedicated units. If you have one person or a couple of people and you are able to put them in a private room along with your health department, that's the key. Utilizing your health department, your local health department. Look, hey, Michelle, who's your health department contact, we have one resident. We're going to place them in this private room. It's a dedicated room for COVID. It's at the end of the hall. We have whatever you've got to do to be able to make it the most safe for your residents. If you utilize your health department and you come up with a plan that is if you have one person and that is the last room that the housekeepers clean, you've cleaned, they've done everybody else, and then they're going into this COVID room last. You've got to use your QAPI process to make sure you're hitting all the things that you can do. And I mean, it would not be conducive to block off a whole wing. When I worked in the facility, we had one of our wings had 21 patients on it. We couldn't block off 21 beds just because we had one person. So you have to utilize your local health department and come up with a plan that is that makes sense. Common sense. Sometimes in long-term care we feel like it's left the building. I mean, common sense has gone, but that's what we have to do. We have to use common sense, and you have to use your local health department and get it in writing. Don't just talk to them on the phone. Ask them to email you some solutions and some answers. But look at the guidance. It gives you, I can't remember. I'd love to be able to spout out the exact verbiage that it used regarding dedicated units, but can't. So we'll look at that and we'll include it in the follow-up as well.
All right, thanks, Pam. Another question that we have is regarding hospitals and nursing homes, kind of comparing the expectations. It says hospitals don't often have dedicated units. They isolate them in private rooms among the unit, and their staff often takes care of multiple patients with and without COVID-19. Why do nursing homes have a higher level of expectation?
Because of over 87. We're more, long-term care is more regulated than, or the second most regulated, the nuclear power. I'm sure you guys, if you've been in long-term care for a long time, you've heard that. And it is true. The regulations that occurred in OBRA, it was OBRA in 1987. That's why we're more regulated. Most hospitals don't cohort MRSA or VRE or any of that stuff unless it's something that requires transmission-based precautions. And by that, I mean, they have a history of MRSA. Yeah, you can go anywhere. It doesn't matter. But if you have active MRSA, I believe they try to cohort, but it's not. Our regulations, long-term care regulations are the most stringent. And if you watch the State of the Union, the biggest overhaul since 87 is coming. So long-term care is but it is what it is. We're good at what we do. Because of that, we make sure that we know what we're doing because we're required to. And our folks, our nurses, our clinical staff, they have to be so clinically competent, and they have to know what they're doing at all times. So that's why, that's the reason.
All right, I'll give everyone just a couple more, like another minute or so to enter any questions that you might have. But Pam, I just again want to thank you for your time and your insight. Valuable as always. Always enjoy speaking with you. I did put Pam's contact information in the chat, her number and her email address if anybody needs to get in touch with her directly. And again, we will get this webinar recording posted on our YouTube channel, and we'll also be posting a podcast with this information as well, and include these links to the file that Pam went over, as well as some of the references that Pam mentioned as well. So I am not seeing any other questions coming in at this point, but everyone's thanking you, Pam, for doing such a great job. And again, we thank you as well. And
anytime.
Right.
And we will be sharing that resource. And again, remember, in Pennsylvania, if there's anything state regulated, it's not on there. It's a West Virginia document, but it's got the CDC guidelines just about testing, how often to test, and all of that. It's a good document, if I do say so myself.
All right. Thanks, Pam. And thanks everybody who was able to tune in today, and hope everybody has a great afternoon.
Thanks.
Bye. Bye.